Hello, bonjour. My name is Margaret Eaton, CEO and President of CSPC. Bienvenue à une autre session de la série sur la politique scientifique présentée par le CPC. Welcome to another science policy session as part of the CSPC virtual series. Before anything, I would like to acknowledge the land that I'm talking to you from, Richmond Hill, Ontario, the traditional land and unceded territory of Wendat, Haudenosaunee, and Anishinaabe peoples, whose presence in this land continued for thousands of years and until today. So for this session, we have a fantastic panel on one of the most important topics of our society in this time, mental health. A group of experts from a wide range of sectors are here with us to discuss the policies on mental health. Today's session is another great work by CSPC volunteers in the event committee. Especially, I would like to name those who participated or contributed to this event: Jane Oldfield, Bailey Smith, Victor Lotuki, and Bipin Kumar, and Trudy Dong, the CSPC Executive Assistant. Also, please note that put your questions in the Q&A box at the end of the introductory session part of the session. Without any further ado, let me invite the panel moderator of today's session, Dr. Wells, to join me on the virtual stage. Dr. Samantha Wells is a senior scientist and senior director of Institute for Mental Health Policy Research at the Center for Addiction and Mental Health, CAMH. Dr. Wells' research examines alcohol-related violence with a current focus on women's experiences of alcohol-related sexual harassment and aggression. Dr. Wells also leads several research initiatives aimed to improve community wellness in First Nations communities using community-based and participatory action research. Thank you, Dr. Wells, for being with us, and over to you to lead the session.
Thank you so much for the introduction, Meredith. Hello, everyone, and thank you for attending our panel discussion today. I'm honored to be moderating this exciting panel of experts in mental health policy. So let's get started right away with the introductions. Firstly, I'm truly honored to be introducing Senator Stan Kutcher. First of all, Senator Kutcher is an internationally renowned psychiatrist in adolescent mental health. He is a leader in mental health research, education, advocacy, policy, and services innovation. He previously worked at the University of Toronto and later at Dalhousie University, where he is was the department head of psychiatry, the Associate Dean of International Health, and the Sun Life Financial Chair in Adolescent Mental Health, ensuring that the best available evidence is used to advance mental health and enable rapid access to effective mental health care is essential to all of Senator Kutcher's initiatives. Welcome, Senator Kutcher. Next, I'd like to introduce Dr. Noella Piquette. Dr. Piquette is a recently retired associate professor at the University of Lethbridge. She has taught predominantly with counseling and education psychology in domains related to supporting marginalized populations. As a registered psychologist, she focuses on preventative and supportive therapeutic approaches with an emphasis on trauma-informed practices. Noella has presented widely in Alberta, across Canada, and internationally on social and emotional learning, gendered therapeutic interventions, mental health wellness, and communication skill development. Noella strives to share clearly laid out, understandable, application-based mental health strategies for practical, empathetic, and supportive interventions. Welcome, Noella. Next, I'd like to introduce Dr. Mary Bartram. Mary has led mental health and substance use policy development, implementation with federal and territorial governments, Indigenous organizations, and NGOs. Mary is the policy director with the Mental Health Commission of Canada and teaches courses in public policy at Carleton University. Welcome, Mary. And our final panelist is Margaret Eaton. Margaret Eaton has served as National CEO of the Canadian Mental Health Association since January 2020. Prior to joining CMHA, Margaret served for 7 years as Executive Director of the Toronto Region Immigrant Employment Council. Previously, she served as President of ABC Life Literacy and held leadership roles with the Association of Canadian Publishers and Magazines Canada. In 2012, she was awarded a Diamond Jubilee Medal for contributions to literacy and culture. And in 2021, Margaret was named one of the Hill Times top 100 lobbyists. So, wow, we have an incredible panel. So I'm really excited to get started. So I'm going to start with you, Noella. My first question is, what are we seeing at the ground level with respect to mental health services in Canada? And what are the pragmatic changes that could improve those services? Over to you, Noella.
First, I had to do that, unmuting. I am unmuted now, correct? Okay, first, I'd like to respond to this by pointing out that we've made some really positive headway regarding mental health awareness in Canada, engaging educators and business leaders in mental health initiatives, primarily through increasing mental health literacy and providing basic skills to support people who are struggling, have been met with both enthusiasm and commitment across Canada. Many of these programs have become virtual and are widely available, meaning we can reach out to an awful lot of people. This has initiated a positive shift in our understanding of the significant role that mental health plays in our daily overall wellness. In addition, targeted community-based mental health promotions and early intervention programs have been found to be both effective and cost-effective. This is a great start, and it's building momentum throughout the community, as evidenced by the therapists that I teach and who practice, as well as the discussions that are held regularly around mental health awareness in homes, schools, and the workplace. But these well-received initiatives do not tell the whole story of our mental health services. There are gaps and barriers faced by those who seek assistance and obstacles faced by those who offer the assistance. In 2020, Moratz and Associates conducted a wide-scale study investigating the barriers that impact services across Canada. Those included not knowing where to go for help, long wait times, a shortage of inaccessible mental health professionals, a lack of mental health service integration, and a lack of government oversight. There's also obstacles related to culture and language barriers, concerns about stigma, inequities due to geography or demographics, and the cost of service often not being covered. These are staggering and sobering evidence that significant changes are required in our mental health services. And as someone with boots on the ground, I have to say that I see this reflected with clients as well as with practitioners. So beyond the barriers mentioned, there's also some overlooked factors that are related to what should be changed. First, there's a significant proportion of the population who are uncomfortable talking about their mental health in general. Why is this a problem? Well, not talking can lead to emotional stress, which has been linked to mental health concerns and physical problems. Talking can assist stress reduction and effective problem solving, as we all know. We need to get to the point that talk therapy and seeking mental health assistance is normalized in Canada. Second, most Canadians find they're unable to navigate the mental health system to connect with someone who can assist them. Part of this issue is that some of the mental health supports are embedded in medical systems, public care, and private care. Over and above that, they're also invisible due to program names or department designations. In addition, each of these systems are also fractured into specific age categories. We need to design a mental health service roadmap that will assist all Canadians in finding all levels of care easily. Third, Canadians living in rural areas or residing within a community that differs from their own culture have a severe lack of access to mental health, medical, and community-based services. We need to be creative in designing respectful, effective mental health supports for this underserved population. Fourth, the high demands for care and barriers in accessing services within the community puts a strain on our hospital emergency departments and physicians' offices through first contact and repeated visits. Note, very few waiting room or medical personnel are trained with mental health interventions. We need to design better access to mental health care services outside of the emergency room or doctor's office. Fifth, Research indicates there's not enough practitioners in the counseling and therapy field, often leading to waiting times up to 2.5 years for services or 92 days for intensive treatment. This is obviously unacceptable for someone who requires assistance. We need to have more trained mental health personnel, including therapists and lay counselors, available to support our population. And finally, for all of these issues, we must ensure that the diversity is addressed within the manner that we provide first contact, and further assistance. This includes being respectful of various cultures and ethnicities, gender and sexual orientation, literacy levels, and so forth. We must break down the barriers to ensure the creation of an inclusive and representative resource and training to include competence around diversity, identity, and intersectionality. So our mental health system has been a well-intentioned, largely disjointed structure. It's time to reevaluate and restructure to a coherent, logically organized system that meets the needs of, and with appropriate resources to support the mental health of Canadians. In other words, we need to ensure that no matter what the services are that need to be covered, that all people have access to the help that they required. This means creating policies that support a seamless mental health support system. Thank you.
Thank you so much, Noella, for your insights on this. Let's open up the floor to the other panelists. Any other comments around what we're seeing on the ground, but also what changes are needed to improve services?
I would just echo what Noella was saying. From the CMHA perspective, we did some research across the country to find how people were responding, particularly in relation to the pandemic. And similarly, our mental health professionals across the country are tired, they're overworked, they're stressed, and they were providing some basic access to things like food and shelter. One of our CMHAs gave tents away to people who'd lost housing. So it's quite dire across the country.
Mary, do you have a comment?
Yeah, I can jump in too. I think that the mental health and substance use health workforce is a really important focal priority for policy and for research as well. What you said, Noella, about, we just don't have enough therapists. I mean, I'm not sure I totally agree that we can't do more with the access point through physicians' offices, but we also do need more therapists. Like you don't increase access. It's a finite resource. If you need to increase access, you need to actually increase the number of people who are trained to deliver services at all points of the kind of continuum of scopes of practice. So I would just amplify that point that and how people are funded and so on is a different policy issue that we also need to discuss. But I do think we are at a point where we need to take a really close look at training, at the education, the seats for various types of mental health providers and how many they are, and whether we need more and of what type, and then figure out how to get those people trained up. So needs to be done systematically with planning and backed by data and so on, but I think it's a really important emerging priority.
Thanks, Mary. I'm gonna turn it over to Stanley for one more point, and Noella, you can wrap up this portion of the panel.
Sure, thank you very much, and thank you, Noella, for those prescient insights. The elephant in the room, there are two elephants in this room, in my opinion. One is the continuation of our thinking about mental health as a silo instead of fully integrated into all healthcare. And as long as we continue that, we will never get to where we need to be, because silos are for grain, they're not for people. So that's the first one. And from a policy perspective, if we continue to go down the road of creating more silos or reinforcing silos, we will not get to where we need to get, which is meeting the needs of people. The second part is, let me be really blunt about this. Our healthcare system in Canada is at serious risk of imploding. It was problematic before COVID, and COVID has been the tipping point. and you're all aware of the discussions going on with the provinces and territories at this point. I want to be really clear in my perspective, throwing more money at this is not going to fix it. We have a challenge and we have an opportunity to rethink how healthcare and mental health care must be part of that discussion. And if it's not, we'll have missed this policy opportunity. But we have an incredible opportunity to think about how the challenges and opportunities here for fixing the healthcare system. The question that we have is, do we have the political will in our federal system to actually do this? And time is going to tell us, because I'm frankly getting sick and tired of different provinces and territories saying, just give us more money, we'll do what we want with it, and the money going perhaps to paying down the debt, perhaps to who knows where the money went. We have to have, at the primary policy level, we have to have a clear discussion about where this healthcare system is going in Canada, and we have to ensure that mental health care is part of the healthcare system. So that's my take on it.
Thank you, Stanley. Noella, do you have one more
I do. I just
thing
like
to say?
Yeah, I'd like to just jump back in. Just first of all, to speak to Mary's point, just to make sure that I'm clear about this, I'm not saying that emergency care and physicians' offices cannot be dealing with this. My point rather is that training needs to be implemented. And I think that that's straight across all community organizations, sport organizations. I mean, basically anywhere that people come together, there should be some training. And you know, the level of that is going to be dependent on a variety of factors. And that sort of fits right into what Stan was saying. Thank you. I appreciate in getting, you know, pulling back and looking at the broader national look. It's not surprising that, you know, siloed industries are having difficulty. But I think that with the training and with the acknowledgement that we need to smooth out some of these silos within mental health and the way that we pay for it and where people go for help, will actually cut down on some of the medical costs, because many times, you know, the doctors and other specialists are being seen time and time again for something that's actually a mental health issue, not a physical issue. But there's no way right now to tease that out. And so many doctors are seeing someone 10, 15 times over symptomatic ailments before sort of gleaning that there is something else going on. And that's time that's being taken away from other patients, but also very unfruitful, for lack of a better word, for the client who's seeking assistance. So thank you. I look forward to the next question. Thank you so much, everyone. Great.
Thank you, Noella, and thanks, everyone. I'm going to go to the next question, and this one I'm going to ask Mary. Okay, where do Canada's mental health policies and strategies sit right now in contrast to your goals and those of your organization in terms of Canadian mental health?
Thanks, Samantha, and thanks for the question. Really happy to be here this morning participating in this mental health policy conversation. So I had the opportunity to be in a leadership role in the development of the mental health strategy for Canada, which coincidentally came out 10 years ago in 2012. And as I look back and then look ahead from 2022, I think there are a few really key gaps that we have yet to be able to address and really need to redouble our efforts for. Equity is at the top of my list. So I'm talking here about gaps and inequities in access to mental health services, but also in outcomes. And as we think about things like, and I know Margaret will speak a bit more about this, universal funding for mental health services, the importance of twinning those kinds of reforms with more action on social determinants, poverty, you know, the tents that you spoke of, Margaret, just so really just bring that point to life. But also support for community level organizations that have the reach into communities. You know, I was on a webinar, I wasn't on it, I helped to organize a webinar with the Wellesley Institute, and there was a speaker from the Migrant Resource Center in Toronto talking about how their organization pivoted to provide mental health supports for Filipino migrants, and they've got the reach, so they need the support to be able to really narrow and shrink those equity gaps. And universal mental health coverage probably won't go the distance in terms of addressing those kinds of gaps. So accountability is another one. So building off of Stan's point, we set a 7 to 9% funding target in the mental health strategy for Canada. And, even that was difficult to develop given the gaps in data that are essential for holding public systems to account for investments in mental health. And while I personally think we could develop increased accountability measures alongside of increased investments in mental health and substance use health. I mean, we still have a mental health transfer that's ongoing. We've got 5 more years. Let's build the accountability framework alongside of new investments. It does seem, reading the tea leaves right now, that accountability framework is a barrier for reducing funding gaps. If we can't get that figured out, we've kind of run into a policy impasse. Mental health and substance use health integration is another really important policy objective, and we've been inching towards that at the national level for a number of years. We saw time and time again in the polling that we did with our the Canadian Centre on Substance Use and Addiction, any mental health indicator that we were tracking, whether it's symptoms of anxiety, depression, serious thoughts of suicide, it was people with a history of substance use disorder that were the line at the top, of the chart. And that the way in which mental health and substance use health are closely interconnected has been true for a long, long time, but really just the pandemic really shone a light on it. And the workforce, the mental health and substance use health workforce, I've already spoken to that. Noella spoke to that as well. People's sort of brain bandwidth stops beyond thinking about the mental health impacts of COVID-19 and providing care for people with COVID-19 in the healthcare system. So when people hear mental health and workforce, that's as far as they get. And while that is like super important, we also need to save some room for thinking about the needs of the mental health and substance use health workforce. Thanks.
Thank you so much, Mary. I'm gonna go to our next question because I feel like our time is shortening here, and we have some really great questions, but we'll have some time for more discussion later, I hope. So I'm going to go to Margaret now. What types of policies and strategies could Canada employ to improve the mental health of Canadians? Oh, I think you're muted, Margaret.
Sorry. Thank you so much. Oh, man. Thanks, everybody. It's really a great pleasure to be here. And I want to start off by telling you a bit of a story about an experience I had in 2019. I was with a group of nonprofit professionals in immigration who were visiting Berlin. And I happened to meet with our tour guide from the Goethe Institute. And he was telling me about the fact that he used to be a dancer. And I said, well, why are you not dancing anymore? And he explained that it was because he had had a mental illness. And he had come from France and started studying in Germany. And he then wanted to tell me that he had had a great experience, that Germany had provided income support for him while he recovered, as well as ongoing treatment for his mental health, to the point where he felt he would be getting back into dance. Now, I'd only known him a few minutes when he wanted to share this story with me. So it just struck me how wonderful that there was no stigma around him being free to tell me about his experience and his delight in this kind of support that he received. And I just thought, why don't we have something like that? Canada lags so far behind other countries in investing in mental health. We spend less than 10% of our health budgets on mental health. But our OECD peers like France, New Zealand, other countries within the European Union spend 10 to 13%. We just don't have the kind of easy access and support that other nations have. But we know that in any given year, 1 in 5 Canadians experiences a mental health problem. And by the age of 40, 1 in 2 Canadians will have or have had a mental illness. And these figures are pre-pandemic. The situation has definitely worsened. And we understand, as is the case with other types of pandemics, that it takes 2 to 3 years past the resumption of our so-called normal lives before people start to feel better and that they've resolved the mental health issues caused by the pandemic. So what is the solution for that? We really believe that the solution is universal mental health care. So what would it look like if Canada had universal mental health care? It would be a system where everyone receives the quality mental health care and substance use treatment they need, provided free at the point of access. It will be a system that prevents, diagnoses, and treats mental health and substance use, and provides the treatment to all, as Mary was talking about, at true equity, regardless of your age, race, identity, ability, gender, income, or region. We also want to make sure that there's the same quality and access to care from C to C to C. And we need to ensure that vulnerable populations, youth, seniors, Indigenous people, and people of the global majority receive care that meets their unique needs. It would also be a system that provides for the social determinants of health, housing, and income and employment supports. But to do this, we need a sea change in how we see mental health, and we need that federal leadership to really match it. So our policy recommendations are that the federal government should first create a Canada Mental Health Act, a legislative framework parallel to the Canada Health Act, to ensure that spending is allocated to mental health and doesn't just disappear into provincial coffers, as happens with much of the funding that goes to the Canada Health Act. This would make the funding long-term, stable, predictable, and overseen by Parliament. It would ensure common principles and standards of provision and care. And second, we would like to see the creation of a mental health transfer. This was promised in the Federal Liberal Party platform, but we want to see a dedicated $8 billion per year for mental health. And even within that transfer, we believe 40% of that needs to be earmarked for community mental health, the non-hospital-based programs and services that so many Canadians turn to for support. And thirdly, we want to see increased funding for the social determinants of mental health. As I mentioned, housing and employment and income, but especially for those people who struggle with mental illness. We know that because of stigma and because of disability, many people with mental illness just don't have access to the housing and income supports needed. We want to make sure those people are taken care of. The federal government has the ability and the financial capacity to make this happen, and they must from a human rights perspective. We can't continue to allow pervasive human rights violations against people with mental illness resulting from our inequitable, inaccessible, patchwork, public-private mess of a system. We can make a huge difference in the daily lives of Canadians, and the time is now for universal mental health care. Thanks.
Thank you so much, Margaret. Common themes are emerging here, which is wonderful. What do the other panelists think about Margaret's point, especially around the, a mental health act, a Canadian Mental Health Act? What are your thoughts on this?
Thank you for that. And I think Margaret has raised many really, really important points. I don't know that the solution is another act that it doesn't help us. So whatever solution that we come up with, we need to be able to work in it, because the Canada Health Act has not provided us with all the actual frameworks that we need to be using and applying, and and there are areas of excellence in Canada in health care which are there in spite of the Health Act and not because of the Health Act. For example, cancer care. If you have a particular type of cancer and you happen to be in Prince Edward Island, or you happen to be in New Brunswick or in British Columbia, you get the same quality of care, the same competencies. When I was a department head, I couldn't tell if a person who came to care in in our clinical mental health system who saw one practitioner got the same quality of care as if they saw a different practitioner. We didn't even have that capacity to be able to measure that, and that was even an expectation when it should have been. So I think that there are all sorts of areas that really support your focus and other people's focus on the social determinants. Look, universal basic income would make, as a policy direction, is going to have huge mental health repercussions. It's not a mental health policy, but it has amazing. The other things, for example, paid sick days. I mean, we just passed legislation that increased the number of paid sick days, but that's only for federally regulated employees. So the provinces and territories have to step up to the plate and say, okay, everybody has 15 paid sick days in Canada. That's going to make a humongous difference to the mental health of people. And we've got disability supports are a joke, frankly. If you're disabled, the amount of funding that you get for your disability is just completely inadequate. And that has a huge impact on mental health of people. So I think that we already have a lot of areas that are within legislation, that what we need to see is the action moving on those components to actually do the things that improve people's lives. So I completely agree with you on the social determinants. It's really an area that we have to focus on. But it has to be both provinces, territories, and the federal government. It can't be just the federal government.
Thank you, Stanley. Noella and Mary, do you want to chime in with some comments around this?
I'll jump in.
Go ahead, Noella. No.
Okay. I'll be brief. So clearly we have a call for action. And I understand what you're saying, Stan, about having a policy with a name on it doesn't necessarily mean that anything is enacted. Got that. My question is, how do we ensure then that we can actually have this groundswell movement to meet the needs of so many people across so many geographical locations with tapped out resources and tapped out providers? I mean, that's the $1 million question here. I don't know what we could do other than pursuing some type of act, because what that does is it brings the issue to the forefront that all Canadians are looking at it and pondering it. And of course, you know, spending 3 years in Parliament trying to get it through. But I mean, at least the information is out there. And I think that that is something that is crucial to any movement right now. It's for people to understand how delicate this system is that is slowly starting to fall apart because of the many demands on it.
Mary, what are your thoughts on this?
I just wanted to point to the National Standards Council work to develop standards for mental health and substance use services in Canada. I mean, it's just getting ramped up, and this is really the leading edge of federal policy right now is the development of these standards through a national standards collaborative. And I do think there's opportunities for people in the mental health and substance use health sectors to be engaged in the development of those standards, and for people in the Canadian science policy community as well to support the development of those standards, and to do our best to ensure that the end result is something that moves us forward into achieving the kind of goals that Margaret laid out, that Noella and I and Stan have all laid out, to make sure that they're connecting back to the gaps and inequities in access to quality care, and connecting back to the importance of social determinants for actually improving outcomes at the population level. So I think that's kind of where the focus is likely to be, and something like a Mental Health Act and advocacy around that helps to hold that process to account for actually achieving outcomes. So that's kind of how I see things playing out, and I do think that everybody can play a role in trying to get us there, get through this barrier to advancing mental health policy in a direction that gets us more equitable access and more equitable outcomes.
Great, thank you. Great discussion. Okay, I have one last question, and this one is for Senator Kutcher. Where do you feel that mental health and mental health policy are heading in Canada over the next 5 years?
Well, Yogi Berra said predictions wouldn't be so hard if they weren't about the future. So I'm just going to be my caveat to this. That being said, I think we're entering a potentially new era for policy directions in Canada related to mental health. And that's because in the last cabinet, we now have a Minister of Mental Health and Addictions. And that's a huge, huge shift in the structural approach to addressing mental health in Canada. Now, that also being said, the role of the minister has yet to be defined. She will do her part in defining that role, but it also needs to be defined within the federal bureaucracy. For example, what's the role of the minister's office with relationship to the public health agency? What's the role going to be in relation to the Ministry of Health? How is that going to sort itself out? And I think we would be Pollyanna-ish if we didn't respect that it's going to take some time for that to be sorted out, and that there are going to be real challenges within the bureaucratic structures of the federal government and the funding allocations that happens, because it's a new ministry. And the current minister has done this once already with PHAC, so she has that experience. She was the minister lead on the public health agency. So I think that we have this incredible opportunity, but it's going to take some time to sort out. The second part, I just do not want us to lose the reality of the relationship between the federal government and provincial territorial governments. And around the healthcare area, it is a new low. There's frustrations on all parts. As a person as a parliamentarian on the federal side, I'll share with you the frustration is that money flows when we don't see the outcomes, and that's a huge, huge issue. The other issue that we find is a problem is the use of best available evidence. How does that get used across the different provinces and territories? Why do we have 10 provinces, each with a different response to COVID, using all the same evidence or not using the same evidence? The big challenge on the horizon that I see that we haven't even started to discuss really in any empathic way on policy is the rise of disinformation and the role of disinformation in the impact that has on people and their own decisions about how to support their own mental health or to support their health. And if you go down some of the disinformation pathways, you end up completely far away from capacity to support your health. So those are big issues that we need to take on. I think that that being framed that way, I think there are three areas. I would love to hear people's opinion about this. One is with the Mental Health Transfer Fund. I hope that that's in the next budget. But the issue here, and as Mary has pointed out, there is a national standards process underway. It's frankly been underway an awfully long period of time. The question is, if and when those standards are created, will they become a vehicle for helping these transfer funds to be actually targeted? And then secondly, will there be an accountability framework that comes with the targeted funds? So where will the money be spent? Then has it been spent in that area? And then third, what are the outcomes? Did it actually achieve what it was supposed to do? We need to have all those. It's absolutely essential that if federal money comes to provinces and territories, the provinces don't use that money to pay down their provincial debt. And it's really important that they don't stop funding, picking up their share of funding to the same topic. So when the daycare funding came, it was written into the agreement that the provinces and territories couldn't claw back their own daycare funding because there was federal money coming in. So this money is in addition to what provinces and territories. Those are key policy, fundamental policy issues. We're not going to get anywhere until we solve those components, and they're really important. The second thing that I think we're going to be dealing with is we're going to have to review COVID and see what impact it has. I mean, I'm frustrated. We're now in the 7th wave, and we don't seem to have learned anything from waves 1, 2, 3, 4, 5, 6. And we keep making the same mistakes, the same communication errors, the same intervention errors over and over and over again. And so what are the issues around that? How are we going to do that work, again, in the federal, provincial, territorial system, so that we will actually see the positive things that come out of that? I mean, there are organizations that have made tremendous positive pivots, the use of electronic technology to deliver care, whether that is face-to-face clinical care, whether it's a Wellness Together portal. You know, we have to have those, the evidence, what is working, what's not working, how did it work, how didn't it work, who did it work for, who didn't it work for. If you're a homeless person with schizophrenia, you don't have a computer, there's no way you're going to get electronic care. So how are we going to learn? What are we going to learn from these things? And that's only just one little piece that we're going to have to deal with. And long COVID is going to bedevil us. I mean, there's a direct neurological impacts of long COVID, but also respiratory, cardiovascular, and gastrointestinal impacts of long COVID. What proportion of people with long COVID are going to have severe illness? What impact is that going to have on our healthcare system? And how are we going to, as a country, come up and deal with that? Because all of those things are going to have major mental health components, not just the neurological sequelae of long COVID. And some of the data there, epidemiological data, is very concerning, but we need really robust national data for that. So, and then the final thing is that, you know, when I graduated medical school in the 1970s, the biggest challenge in mental health care, in the whole mental health area, was rapid access to effective care. It's still the biggest challenge. And you know, we've gone somewhere, but we haven't gone where we need to go. In my perspective, what we need to do is ensure that the primary healthcare system in this country is rock solid. The people have a primary care physicians. The physicians work in primary care teams that include counselors and therapists. And the team is a basic, regular primary health care team, you know, along with nurses, nurse practitioners, nutritionists, physiotherapists. That's where we need to move, because that's where the rubber hits the road. And we can, you know, Noella and Mary and Margaret all talked about the importance of providing that face-to-face care. It has to be through these things. It can't be standalone without accountability. Health human resources, people have already talked about that. We need to make sure that we actually have the workforce with the skill sets. You know, I was talking about this at the WHO 20 years ago, the creation of resources allocated to scope of practice integrated into the healthcare system. You know, we're still not there. And our medical schools and our nursing schools and our physiotherapy schools aren't producing graduates that have those mental health skill sets. They have to start doing that. But also how to support those people who are in the healthcare field. The COVID has shown us that burnout is huge. I mean, our healthcare providers, including mental health care providers, have carried this huge burden. And people are leaving the professions in droves. And you know, so how are we going to support our healthcare providers? How are we going to create new healthcare providers? It's essential to do that. Statistics. We don't have common population level measures of mental health that are going on. And Mary's heard me rant about this over and over again. And we actually try to do some of this, and we're not successful in it, but to try to ensure that there is standardized, annually recurring, validated population measures of mental health across Canada that includes proper disaggregated data of significant numbers of vulnerable, marginalized, and Indigenous peoples on and off reserve, so that we can actually have a snapshot, a picture of understanding of what's actually happening across this country. We need good administrative data. Who's going to what services and where, and can they access them? How long is it taking? And the third thing, we have to have good outcome data. We don't have that. So when I'm looking at where are the big policy areas that are coming up, those are how I see the big challenges. But within that, there are two things I want to identify. People have already mentioned these. One is the minority groups, the equity-seeking groups. I mean, we have to ensure, and Mary said that, the number one on her list is the equity seeking. We have to make sure that we are addressing that need. And then Indigenous peoples, we have to not only think of reconciliation, we have to think of reconciliation. And so what are we actually going to do to promote and direct this? So that's where I see the challenges that we're going to face in the future. And I think and the final thing I'm going to say is one of the big challenges is going to be keeping our focus on the major challenges and not getting hived off on activities that make people feel good for a short time, but really don't make the structural, legislative, and fundamental changes that we need in our healthcare system and the provision of care. So that's where I see it, but I could be completely wrong.
Well, thank you so much, Senator Kutcher. Fabulous, so many amazing points. And I don't have time now for discussion, but maybe when we get to the Q&A, we'll have time for more discussion among all of the panelists. So thank you all so much. Before we get started with the Q&A, though, we have to take a moment to answer this webinar poll. And I believe someone will be putting that poll up right away for everyone to complete, and that will be done, and then we'll get to our Q&A. Okay, I think everyone has finished the poll. And so we can now, I think, get started with the Q&A. So I am going to ask people to enter their questions into the Q&A. And I'm going to get started right now with the first question because I'm mindful of time and I really want some more discussion here. So the first question is, and I'll open it to everyone, are there some examples of mental health supports being integrated in Canada? How can mental health support be integrated into schools, for example? So I'm opening up the floor to all of the panelists here. So go ahead and jump in, please.
I'm going to jump in. It's Noella. They certainly are being integrated in schools, particularly at the elementary and junior high or middle school level, that there's a concerted effort to bring forth a lot of mental health literacy. There are counselors that are embedded in all of the school systems in urban centers, and I want to make that very clear, in urban centers only. There's a great deal of difficulty in finding the resources in rural, and there's a lot of virtual resources and pop-up clinics that have occurred around educational systems. So there is some traction.
If I could just follow up on that point, I think that there are some provinces which are starting to move in this area well. I know there are major initiatives in Alberta, Noella, which are good to see. There are, British Columbia has had outstanding address of some of this throughout their 92 different school districts, integrating mental health literacy into the structures and then counselors into the schools. Youth-based health clinics in schools are a fundamental way of moving ahead. The research on youth health centers in schools is just fantastic, but we're not using them in Canada. And they're inexpensive and a very effective way of meeting needs, particularly in rural and remote areas. And so there are some really, really good directions. University of British Columbia and other universities have created a complete online training program for teachers because teachers actually have to have this in their pre-service teacher training, understand these things, it's all there. And much of it is uptake and willingness. And what I see across the country is different provinces and territories fighting with each other about, I'm going to do it my way, instead of saying, Alberta's doing a really good job in it, why don't we take this and put this in Ontario? They're fighting about who's doing what to whom. So I think there is some glimmers of positivity, but a lot of way we have to go.
I'll just, I mean, the principle that providing services where people spend the majority of their time in terms of access makes a ton of sense to have more supports available in school systems, in post-secondary settings, in workplaces, in long-term care facilities, et cetera, right? But the risk is that we don't think about this as a whole systems approach, right? So we end up with capacity to provide services in the school system not connected up with what's happening in primary care or in the CMHA in the community. Sometimes that happens, sometimes it doesn't. And then in addition to that, kids have access through the private sector, through their parents' plans, through out-of-pocket payments if their parents have enough money to do that. And that's also not integrated together. So we just need to be careful when we're creating these targeted approaches that are setting specific, that we're thinking about the whole system, both from an access perspective, but also a human resource perspective. So we're not, for example, hiring people to work in post-secondary settings as mental health therapists or counselors or whatever the scope of practice or title is that is set as a parameter. Where are they coming from? Is there a net benefit to the population as a whole? And if we don't have that system level perspective, then we can start to feel like we're doing great things, but we're forgetting that we might be making advances over here and falling further behind if the CMHA in the community has suddenly lost its counselors because they got jobs on campus, right? So,
Margaret, any comments as well?
I do think this issue of integration is just huge. It goes to Stan's point about primary care being connected to community. And someone else has asked a question here too. What about people who suffer from a major medical procedure and then experience a mental health care issue? And one of our concerns is there isn't great connection between hospitals and psychiatrists and what actually is happening in the community for mental health. And so I think integration, and to Stan's point, breaking down these silos is just incredibly important as we think about what are the systems changes that we need. I spoke with one hospital administrator who said to me, well, a lot of times hospitals can be a little bit arrogant, thinking that they can do it all. And then someone goes, they're finished their treatment, and then there isn't follow-up, or there isn't the support that could or should come from the community to actually provide the additional hand-holding that you need, that can't come just from your hospital or your GP. It's going to come from community support. And so strengthening those connections, I think, is just going to be so important as we make systems change.
Thank you. I have another question here, and it's about first responders and safety personnel, and knowing, of course, that many have been traumatized and they need specialized trauma-informed care. So can this be done within the public system, or does it need to be a standalone stream for healthcare?
I think when referring to vicarious trauma, it has to be embedded, because although first responders certainly have an awful lot of our attention because they're right there, but there are so many other people who work with individuals who have been traumatized, who they themselves end up becoming traumatized. It needs to be throughout all of the mental health supports.
I think this is similar to my example about the Migrant Resource Center in Toronto to some extent, that we need what Noella just talked about, but we also need the community supports and really like culturally specific supports to have stronger capacity. So I met with someone from a veterans organization last week, and they provide a lot of tailored services and programming. Again, there's a bit of a risk that this becomes another silo, but I'm guessing that they also they reach people that way that might not go to their doctor or seek help from CMHA. So I really think it's a both and. Like Michael Marmot talks about proportionate universalism, that we need universal access, but we also need targeted approaches. If we don't have both, we don't actually narrow those gaps. And I think that applies to a lot of different groups with unique needs, whether it's first responders or Filipino migrants or people living in remote communities. You kind of need that both and approach.
Margaret or Stan, would you like to weigh in on this?
Well, I think it's been well said already. One of the big issues around targeted approaches, if they're not at least well linked to existing healthcare, you end up with chaos because say you're treating someone and they run into a severe problem, need hospitalization. If you're not linked into the system, try to get in. It can't be that way. It has to be. There's certainly room for specialized interventions, but they can't be standalone only.
Okay, thank you. So I don't see your hand raised, Margaret. So shall I move on to the next question? Okay. So, and I know you partly answered this, Margaret, but maybe I'll open it up to the floor. And that is, often a major medical procedure, such as heart surgery, can lead to a mental health issue. Should there not be more supports for these patients post-operative to deal with this? And I think, Margaret, you already kind of touched on this. Any other additional points around that? And I know you earlier on, there were some comments around, you know, physical health and mental health and how to sort of integrate services around that. Noella.
I was just jump right in. Absolutely, there should be integration, but it should go the other way around as well. That a therapist working with a client who realizes that there are some medical issues, that there should be some, you know, going back and forth. I can't emphasize enough how much I agree with Stan's and Mary and Margaret's take on that we need integrated health, period. It needs to move back and forth. And I know that in Alberta, we looked at primary care 2 premiers ago, and it was met with suspicion at that point because people didn't understand how effective sort of the one hub would be in moving back and forth effortlessly. But I would love to see that happen again. We absolutely need to have the medical professionals and the mental health and all of the other components of helping professions working together. I'll leave it at that. Thank you.
Thank you, Noella. Mary, and then Stan.
So I think we've just got this situation where there are gaps in access. So then people, that spurs this identification of a need for like a niche service for a particular issue. And, you know, we can't forget that physical health care has a different funding base than mental health care in this country. So, you know, that's one of the big challenges, and that's where I think universal funding for mental health care can actually take us some distance. I don't know how politically feasible it is, but I think to put physical and mental health care on an equal footing. So when we're talking about primary care teams, as Stan was talking about, the way that they're financed it's similar, as opposed to right now where you have the physician services able to bill and then or on salary, and then the ability to support the OTs or the physiotherapists or the mental health therapists reliant on kind of grant-based funding. Like that's just it just doesn't result in the kind of advance that we are seeing a need for.
Thank you, Mary.
Yeah, I would agree. And the data on providing care for post-surgically, we've known it for decades. It improves outcomes, decreases hospital stays. It's economically better as well. People get better faster and they get more better. If I can use that word, more better. I have a good friend from Newfoundland who's cottage over. He uses that all the time. I love it. But it captures the essence of this, and it's cheaper. But we just don't do it. But that being said, some specialized programs have already started to do this. So cancer care, for example, has a psychosocial component to all cancer care. They don't need a psychiatrist, for crying out loud. They have a social worker with the skill sets. They have counselors with the skill sets, nurses with the skill sets. They integrate that into that. So it can be done. Mary put it quite well, I think, is that the funding envelopes have to be such that facilitate that. Not the funding envelopes are barriers. They don't facilitate integration.
Sorry, Stan, to interrupt. I'm just seeing the clock here. It's 12 noon, and we have run out of time. But I would just love to thank you all for your insights, your incredible thoughts around mental health policy, and just a fabulous panel. So thank you all so much. I really appreciate it. There is a feedback poll. Can people fill that out, please? And please stay tuned for future events from CSPC. And be sure to check out the CSPC website for social media and other details. And thank you all for coming to this fabulous event. And do look after yourselves and have a fabulous summer. Thank you all. Thanks, panelists.
Thanks, everyone. Thanks, CSPC, for putting this on.